And next we have Gordon Caldwell, a consultant physician at Worthing Hospital on the south coast of England. Again, Gordon is someone else that I came to my attention through Twitter. He'd been tweeting an awful lot about leadership and in particular ward rounds and the role that they can play in patient safety. So I was very keen to learn more. Over to you, Gordon.
Thank you, Jonathan. It's a double challenge there to follow on after Umesh. I don't think I'll be able to reflect his humour and his passion quite as much, perhaps, and then to finish before 11 o'clock so I don't have an enforced 2-minute silence during my talk.
Yes.
About 12 years ago, I was looking after a man who's about 75, and I think he was a retired builder who was a smoker, and he'd come into hospital with a fairly severe pneumonia, which we treated with intravenous antibiotics and made a very good recovery from that. And on the ward round, we're getting to the stage where we're talking about time to get home, go home, and he pointed out a problem with his left arm. And on his left arm, where he'd had his cannula for his intravenous antibiotics, he had a boil on the arm, and he had septicemia. It was an MRSA septicemia. And that brought home to me that we can have the most tremendous treatments for medical conditions, deliver them really well, save people from life-threatening illnesses, and through an error of omission, which in this case was failing to remove the cannula when the intravenous antibiotics were finished, we caused that man harm. He needed 2 more weeks in hospital to get his MRSA septicemia eradicated and treated. And he allowed me to use a photo of his arm for a PowerPoint on appropriate time to remove cannulas from patients and to avoid that sort of harm. And when I talked with him, I said I'd do everything I could to try to make sure that those situations didn't happen again. And I can remember talking with our chief executive and our registrars about could you have a routine for a ward round so we never miss things like that ever again. And the registrars never came up with anything. So I'm going to talk a bit about the importance of ward rounds. Does your organisation value ward rounds? I know that hospitals value outpatient attendances and they value theatre lists and waiting lists because you measure them and report them all the time. But I think that ward rounds are undervalued. And if you value something, you'll measure it. And you have to be very careful about what you measure in medicine. We have to measure what it is that we really value, which Umesh has shown us in his talk. I think the best example, or worst example of measuring the wrong thing was the 4-hour target in A&E, where it's easy to measure when somebody arrives, easy to measure when they leave and where they go to. So that's what was measured, and all the emphasis was put on speeding people through that system, rather than what we really valued, which was could we make a good diagnosis, deliver the treatment on time, with happy patients and happy staff, all within the 4 hours. So this is somebody trying to measure happiness, which is very important. As Umesh has said, we've got to have happy patients and happy staff. If we value happiness, we've got to face the difficult task of measuring happiness. So don't just measure what's easy to measure, value the other aspects as well. So if your organisation isn't measuring ward rounds in any way, I would suggest that you don't really value the importance of ward rounds. So in my experience, even simple measurements of ward rounds aren't taken. How many rounds are done each day? How many patients on each round? How long do the rounds take? What time in the day has every patient had a thorough clinical review? Is it 11 o'clock in the morning or 6:30 in the evening before everybody gets a thorough review? What happens on that ward round, and is it done well? And if we aren't measuring these things, aren't getting the right quantities, the right qualities, then our cooking will fail, and our cooking is very important in acute medicine. What I'm hoping to do in this talk is to give you some thoughts which you'll think about whilst you're going home on the train or on the plane, rather than a lot of answers. Sidney Decker, who comes from transport safety background, initially airline safety and then other transport shipping industry, moved into patient safety now, and his books are really readable and valuable on just culture. And he talks about the greatest threat to modern complex organisations being what we accept as ordinary. If we accept as ordinary that drug prescriptions are illegible and that the nurse is squinting at the drug list to try and work out what the medication is, then we will inevitably end up with drug errors. And you watch out for what we accept as ordinary. If people are saying that's the way it is in the NHS, what do you expect in the NHS? This is what's ordinary. And one of the problems with ward rounds is that they're so ordinary that I think people haven't paid attention to them. And I can guarantee you that if you're running shoddy ward rounds, you'll get shoddy care and shoddy results. Whilst I started thinking about this talk, of course, it struck me that in airline safety, which we talk a lot about in healthcare these days, you're starting off in an inherently safe situation. You've got a safe plane, you know that everything's fixed and working, and you're hoping to get to the destination. And I'm pleased to hear that our colleagues from Vancouver have arrived safely after I posted this and said that there's a similarity with airline safety. Our patients are in danger as soon as they come into hospital. They've come into hospital because there's something wrong, there's something broken, they're in a dangerous situation. And our work is to take people from that dangerous situation and to make them safe and to make them better. It also struck me looking at those pictures that a whole lot of our patients don't look to be in that much danger. They aren't on fire, they haven't got knives stuck into them, and yet their health can be in great danger. There's a lady who came in about 2 weeks ago who's died since she came in. She looked fairly well. She had a little bit of jaundice. She was in her 80s, and she had underlying metastatic pancreatic cancer from which she died. She didn't look to be in that much danger. I want to set the talk about ward rounds in the context of acute care. So what is our work in acute care? I think it's to take a cohort of ill patients. It's important to think about a cohort of ill patients rather than just one ill patient and then the next ill patient, because it's our responsibility to take all those patients and make sure that they get the proper care. And then our work is to restore their health swiftly and safely so they can resume living outside hospital. But for a small proportion of our patients, it's to anticipate and provide for a calm end of life. And that lady who died of pancreatic cancer, we were able to make sure that she had a calm end of life. And also, we should always be learning to do it better. So this is what I call the rights of clinical care, that as doctors, we need to be making the right diagnoses, providing the right treatments, at the right time, at the right place, and the right pace is really important. Can we keep up with all the illnesses in that cohort of patients so that we don't get overtaken by the illness because our processes are too slow? When we were developing a ward round checklist, Atul Gawande said to us, don't do anything that slows the overall pace of clinical care. And a lot of changes have happened in hospitals in the last 15 years, which seem to me to have slowed our processes down so much we're in danger that the diseases run away quicker than we can treat them. There should be a right to no avoidable harm and better next time. I put up this slide in the clinical, what I call the clinical care cycle, because I think as doctors we don't really explain this very well to our managers and to our colleagues. What we try to do is to establish a diagnosis in our patient, and increasingly with our elderly frail population, diagnosis and comorbidities. So not only does the patient have pneumonia, but they've got COPD, type 2 diabetes, chronic kidney disease, Parkinson's disease, and they've got bowel cancer, all in one patient. Then we have to make treatment plans for all of those problems, deliver the treatments, monitor the patient with our vital signs monitoring, blood tests, clinical review, and the review of progress happens on the ward round. That clinical care cycle in acute care happens for all patients, I think, apart from the patients who come into resus, who go straight into treatment before we do the diagnosis and the planning. So I wanted to talk a little bit about how doctors make diagnoses, because I think this is really important, because misdiagnosis, I think, is the leading cause of harm to patients. If I treat a patient for pneumonia and they're actually having recurrent pulmonary emboli, the patient is likely to die of pulmonary embolism. I've done that, I've made that mistake. I've seen a patient die from pulmonary embolism who I was treating for pneumonia. So misdiagnosis in terms of patient safety is probably the biggest threat, although we tend to think that it's medication errors the biggest threat. How a doctor makes a diagnosis is to listen to the patient, tell the story of their illness, how it's affected them, know about the previous relevant medical conditions, so know about the chronic kidney disease, the bowel cancer, the COPD. A medications list is hugely helpful, and it's only in the last 6 weeks that I've been able to access the patient's medication list that's given from the GP online, real-time, at the patient's bedside. Social history, smoking, alcohol with their living conditions, and the previous expert synthesis, the discharge letters and some clinic letters, hugely valuable to doctors. It's the first thing they'll grab if they're given a chance, is the last really good clinic letter to get an overview of the patient's health. The vital signs examination of the patient's early tests and thinking time all go towards making a diagnosis. So the preparation and cooking time for a diagnosis with comorbidities, Umesh was talking about his junior doctors, this is what our juniors are doing all the time. If they could have 10 minutes undisturbed time to interview a patient without the bleep going off and a nurse coming in saying, can you write up some paracetamol for the patient to the next bed, that would improve the quality of diagnosis hugely. They could have 10 minutes undisturbed time to examine the patient, again, would be tremendous. They could probably cut that down to 5 minutes each if they're really undisturbed and can concentrate on the work. Take the vital signs may take 2 minutes, and then the series of question marks, previous history, medications, previous expert synthesis, and early tests. The question mark is, this can take forever. You're arrived in our hospital acutely unwell, and we don't know that you've got breast cancer, and we don't know what chemotherapy you had in a hospital 10 miles down the road, and this is the middle of the night and you're seriously ill. And sometimes it can take forever to provide that information, so leading to misdiagnosis. And thinking time, 5 minutes thinking time, undisturbed thinking time would be really helpful. So that tends to be a very slow process, and sometimes the patient's been in hospital for weeks and we still haven't finished all those bits and got all those bits of vital information for making diagnosis. The productivity in this could be improved dramatically. Most people arrive in hospital via ambulance, or you know they're coming in already because the GP's phoned in. And we could have a reception area well supplied with IT, with the access to the clinic letters, the discharge summaries, previous results, all there ready, simultaneous assessment by the nurse and the doctor, get some early tests done, and I think we could be diagnosing patients in 30 to 40 minutes and getting their treatment started, if we're really concentrating on productivity, value-added work with our patients. The extra bits we need, vital signs, blood tests, ECG, radiology, wait for the results and think. Again, undisturbed time to think, really important, can lead to the diagnosis, comorbidities, confounding factors, early treatments, and send on to safe specialist care. Safe specialist care in one patient might be the intensive care unit, coronary care unit, another might be back to the very safe care of the general practitioner. So the ward round fits into that model with the review of progress. Every patient, doctors again don't really talk about this, we anticipate a trajectory for the patients. Obviously what we're hoping is, like this rocket, that they'll start off on ground level in the hospital and very soon be in orbit outside of hospital, back in the community, living life successfully without the need for hospital care. And we anticipate a trajectory for every patient. And it's on the daily ward round that we try to work out whether the patient's making the expected progress against trajectory. So on the ward round, we're trying to work out, are the diagnoses correct? Have we made a misdiagnosis? Is the patient making progress as expected, and is that by good luck, or is it by good planning? If we give an antibiotic for pneumonia, that same antibiotic might work for pyelonephritis, so by good luck, we got the patient better. Are we protecting the patient from avoidable harm, and are we preparing for discharge? So that's what's happening on a ward round. Now, I don't think it's just because I'm getting older, I think it's because medical care is becoming more complex. I've come to realise that memory is an unreliable tool in high-risk working. You probably know the game Kim's game, where a number of articles are set out in front of you, you've got a minute to look at them, then one article's taken away, and you've got to remember what it was that was taken away. Now, that's a difficult enough game to play, but in medicine, what they don't tell you is that there's a box on the table, and inside the box there was an article which was a urinary catheter, which you never saw, and then somebody has or hasn't taken it away. So you've actually got to go around looking for stuff all the time and finding out the things that were hidden that need to be revealed to make the patient safe. So we work in a very complex situation. In the last year, I've been accustomed to seeing between 15 and 30 patients on a medical ward round. Each patient has 5 or more important diagnoses and comorbidities. As I said, they have pneumonia, COPD, type 2 diabetes, chronic kidney disease, and bowel cancer. And many have more lists than that. Many medications, many aspects of the monitoring, are they advancing to a trajectory, and we've got to protect them against harm, and we've got to communicate well, we've got to do good handovers. So this raises the question, on a ward round, what is doing it all? I used to, I still do, I let my juniors do the bedside consultation, some of them lead the whole ward round. And at one time, Foundation Year 1 doctor back in 2009 led the ward round, and at the end she said it was a good experience, she felt very supported by us, but she worried whether she'd done it all. So I sent the team away and said, come back in 2 days' time, tell me what you think doing it all is on a ward round. What should be done for everybody, what boxes you should open to check that the catheter's been moved or not removed, whatever it is. So we came back after about 2 days and we developed our first checklist for our ward round to make sure we're going to do it all for our patients. At the moment, that's got something like 22 different checks for every patient. If that's 30 patients, that's 600 checks on a ward round. The detail of this isn't important. What matters to you is, if your consultants are doing complex, high-risk ward rounds, what do they think is important, what should be done for everybody, and how are they going to know they've done it? Because if only you've got a reliable process, you get a reliable outcome. This is our solution. There's plenty of other solutions. It follows the way that the consultation goes. There's a consultation on clinical progress, there's future planning, active safety checking, and communications in the written notes and what's spoken. The 7-point active safety check that we incorporate into our ward rounds is very simple. Asking the patient about pain and discomfort, as Umesh has talked about, food and drink, or hydration and nutrition, if you want to be really smart. We use much less intravenous fluids than we ever did before, just because we ask the patients if they're eating and drinking. If they say no, then we ask the nurses on the intentional rounding to make sure the patient's offered a drink and that they drink it. And cut down the amount of intravenous fluids hugely. Have they got a cannula or a line in? Or they've got a catheter in, and catheters can be hidden and almost invisible. Similarly with cannulas and lines, I've found I can stand by the side of a patient's bed, have a long consultation with them, and completely ignore the fact they're on intravenous fluids and not to have their fluid balance worked out and decision about how long, whether to keep the fluids running or not. Constipation or diarrhea, pressure area care, and should we change the VTE prophylaxis? Ask those 7 questions to every patient, every ward round. This is teamwork. No one person can manage this any longer. There's just too much going on. There's too little time to do it properly. I have a system of sign-in for my post-take ward rounds. The junior doctors I've never worked with before, I get them to sign in, to commit to the ward round, that they're going to contribute, they're going to tell me if there's errors, they're going to tell me if they've got any concerns. I assign roles. The registrar's job is to look at the drug chart, is to report every drug that the patient's taking, and to watch out for the medications that should be stopped, started, or changed. We anticipate how much work there is, we have a process, and I'm not very good at the debrief and learning so far, need to improve on that. So how long does that take to do properly? This is Worthing Hospital, my team, my unit, and you'll get a different answer somewhere else. I've done 322 post-take ward rounds since I started using these checklists, 3,046 patient reviews, 15.2 minutes per case. That's to hear the case from the junior, look through the radiology, the blood tests, go to the bedside, consult with the patient, sum up at the end, make sure it's all documented properly, and do a short debrief at the end. For the review rounds, 11.5 minutes. And Umesh was talking about inefficiency in the NHS, huge inefficiency in that system. We could probably cut those times by a third with good IT systems, good organisation, getting better quality, better outcome than we're doing at the moment. Also do some it's important, better next time, training the juniors. Do I think they're looking after the patients in the way that I would want to be looked after if I was ill? If their documentation is scruffy and illegible, I don't want to be in hospital like that. I want somebody to write quite clearly, acute inferior myocardial infarction, I've contacted the cardiologist and he's going to the cath suite. I don't want people wondering what on earth's written there. So would I be happy with them looking after me? I train them in teamwork by using the checklist. They learn to speak out, to talk about error, to talk about omissions. So I teach them active safety control, and we learn from our patients. 3 weekends ago, we had a patient really ill. We thought she might die of septicemia. In fact, what was wrong with her, she had adult onset Still's disease, diagnosed by a rheumatologist Friday, transformed by steroids over the weekend. Our whole team knows about adult onset Still's disease now because we've seen the patient, we've learned from the patient. That's where doctors learn about clinical care. It's from the patients we care about. So we learn from our patients. So what should we be measuring if we value ward rounds? Well, first of all, I think, do the ward rounds happen? Are they happening on time? Do they have a prompt start? Is the full team there? At the moment, on my ward rounds, I have a nurse at the bedside on my routine ward rounds less than 30% of the time. The team is not there. Dan's seeing this himself. How many patients do you see? Is there an agreed process for the ward round, and are you compliant with that process? How long did it take? Has everybody at the end of the ward round got a shared mental model between the patient, the relatives, the nursing staff, the doctors? What's going on here? What's the plan? What's going to happen next? And what's the patient understanding and satisfaction? The picture there is about appropriate handling of qualitative data. We're very poor at handling qualitative data in healthcare. This tells you that 20 out of 22 readers really thought Atul Gawande's book Better was tremendous. They didn't reduce it to some funny statistic with percentages and things. Shows you that people really think that's a good book. We need to handle qualitative data properly for our ward rounds. So, Oscar Wilde wrote The Importance of Being Earnest in Worthing. I'm from Worthing, and I think in Worthing Hospital we've put an appropriate emphasis on the importance of ward rounds. They have been undervalued in healthcare. They're crucial to safe patient care, crucial to high quality care, crucial to the rescue of patients from illness with no additional avoidable harm. They require a lot of optimizing. They are very difficult to measure. They're enjoyable and very important. So Oscar Wilde published The Importance of Being Earnest about 100 years ago, or a bit more than that. This work from the Royal College of Physicians and the Royal College of Nursing was put together very much on the basis of the work we'd done in Worthing Hospital. So I'm proud of this publication, Ward Rounds in Medicine, Principles for Best Practice. Thank you.